Hey everybody, welcome to EMS Office Hours. I am Jim Hoffman,
And I'm Dave Brenner.
and we might have Josh joining us. Dave, I do not see him in the
You're just
queue here or
joshing.
anything yet, but we shall see. Um, Maybe he shows up and we can talk. But like you said, I think he's been very uh, passionate
Distracted.
about distracted other endeavors. So we shall see if he pops in. So it'd be nice for him to show in. So, guys, you're listening to the show, you're watching the show. Be sure you go to emsofficehours.com. You can see previous episodes there. And do me a favor, real quick, just hit the like button. Let me know that you guys are watching and that you're in the feed. And then if you comment and whatnot, if you're on Facebook, I can see the comment and kind of mention whatever it is that you're saying as we go. So today, Dave, something I wanted to do this last week. We couldn't do the show because I got a little bit of a family issue happening, but I wanted to jump on today and kind of revisit this because I think it's important to point this out. And while this is something that is talking about specifically New York City and FDNY and their guideline for this, I think this is something that a lot of agencies throughout the country are starting to struggle with, and that is people calling 911 to get a COVID test to be seen for non-emergent issues because they think they might have COVID because they have some other sign or symptom, and they might not be, very symptomatic or have an emergent issue with potentially having COVID, even if they do. And the FDNY put out a policy about transporting patients to the hospital of their choice. In the past, Dave, as most of the time, wherever the patient wanted to go, you pretty much took them there within reason. And even if it was out of that, they have what they call a 10-minute rule in New York City, which is 10 minutes beyond the closest facility for that patient. So it could be a 15-minute drive, even a 20-minute drive, and you'd have to get permission from the online medical control to transport them to a further hospital. But this protocol, this guideline, because of the overwhelming call volume and shortage, I think, of providers that are out there, is now they are determining the hospital based on what the computer tells them. So whatever the facility is being determined by the computer when they get on scene, and that's the hospital that's supposed to be taking the patient to. And reading from the protocol, it says that if the patient refuses transport from the computer recommended facility, and the patient is qualified to refuse medical assistance, the RMA, and they have full decisional capacity, then the RMA should be secured. Unless they're a pediatric patient, then you have to have
Then you can get it from their parent, right?
Right. And then, of course, the crew is going to document appropriately what the capacity is and that they understand the risk, blah, 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 blah. Now, there is the end of this where it says that if the patient is still insisting on transport and you can't convince them to be transported to the closest facility and yet they still refuse to do the RMA and maybe get to the hospital on their own, then the crew is supposed to contact medical control for a transport decision. I haven't seen anything in comment threads and stuff like that, Dave, where they are, some experiences from crews that actually, did the refusal and then called medical control, and then the patient was able to go where they wanted. So I'm not sure if it's just some kind of a verbiage of this policy getting put out, and it doesn't really matter anyway, because when the patient insists on going where they want to go, and you call medical control, goes, yeah, go ahead, take them where they want to go.
Yeah,
I've had that. I don't know if you've had that, Dave, but I've had that in the past where the patient wanted to go to a further hospital, and I stomp my feet and I tell them, no, you got to go to a closest hospital. You really need to go to a hospital that's closer. Your doctor's not waiting for you at the ER, blah, blah, blah.
Yeah.
And then I call the doctor, and the doctor goes, yeah, take them.
Well, yeah.
Yeah.
So there are certainly at least two issues with this. You know what? Maybe we can get resolution to the experience if we have any listeners out there who are in the Finney or the volunteer hospitals within New York City who can tell us, hey, I just did this yesterday. This is what happened when I called medical control.
Yeah,
that
I haven't heard of anything. Yeah, I haven't heard anything on that.
Yeah, one of our listeners is telling us it's because there's a shortage of EMS crews, and certainly we know that there's a shortage of EMS crews, and we also know that it's inappropriate to call an ambulance just to take you to the hospital to get tested. Listen, we take sick people with COVID to the hospital all the time because they're sick.
Right.
And yet we find a lot of other people some of them are really sick, and they drive themselves to a doc in the box, to one of to an urgent care facility.
Right.
Yeah, and they're able to do that. And then from there, the urgent care facility calls us to take them to the hospital, or they could have gone to the hospital directly on their own and chose not to.
Yeah.
And so we, in these times where there is a shortage of resources, and that time counts, because even with the resources we have, if somebody wants to go to a further hospital, 10 extra minutes. You could have been ready for another patient, a really sick patient, and it's not gonna. The system's down. It's a bad time, made worse by people abuse it. I want to give you just one of our recent experiences. We have an intermediate care facility for people with disabilities, and they reside there. And we get a call. One of our providers says to us, we got a call, and the documentation was interesting. It said that a worker there felt that they were exposed, and it is the policy of their agency. I'm not going to name their agency. That if exposed, they have to call 911 and get a medical transport to a hospital to get tested. Now, from my point of view, I would love to meet with the administrator who made that a rule. It's heinous. It's a complete disregard for what emergencies are all about. It's abuse. And in other places where they charge for medical transports, they might welcome a call like that. But in my system, which is predominantly volunteer, even if we have paid staff, we don't charge anybody for it. We just charge the tax base for it, because nothing happens without money. It's abuse. Listen, if this is what happened, you got exposed. I tell you what to do. If you believe you need an ambulance, call a paid ambulance.
Yeah.
Call a paid ambulance. They'll get there. They don't have to be there in 7 minutes. They could be there in a half hour. You got exposed. What do you think's going to happen in the next 20 minutes?
Yeah. And I wonder when that happens too, like do these ambulances end up responding to a call like that, lights and sirens, not knowing what's really waiting for them, depending upon what information is given when the call comes in,
Well, now you're going down another rabbit hole. It's the emergency medical dispatch rabbit hole, which I would love to talk about perhaps in another episode of us. Part of what happens with emergency medical dispatch is garbage in, garbage out. If the patients lie to us, if the caller lies to us, some of them were told to say they have chest pain because you'll get a faster response.
Yeah.
Wow.
Now I saw a lot of comments when this policy was first put out. Apparently there was something like this or similar to this when COVID was at its height. Back when they were getting like 6,000 calls a day, they put something like this out to try
The
to at
state
least,
put it out.
yeah. So so now this is kind of being reintroduced because of the new variant and the people getting easily sicker with it, and then freaking out because they have some symptoms and they want to go to the hospital. Um, in addition to this, I think that New York City, the fire department is trying to figure a way to, like you had mentioned, right? That 10-minute rule. That's 10 minutes of getting the ambulance that could be turned around a little quicker to get back in service for a real emergency, a true emergency that might be out there. Um, and now I saw a guideline where they're going to have some kind of an algorithm to help with the patient loading at the hospitals. Have you seen that? Where they're talking about
They're
it
do
doesn't matter.
triage.
What's that?
They're going to do triage.
Well, what they're trying to do is they say, okay, the algorithms has something going on where one hospital has been getting a lot of patients transported to it. So now the computer is going to recommend other hospitals who have not been having a lot of patients transported to them, even if it's not the closest facility. It's the closest facility that has a less of a patient load.
Like what we do
So
in an MCI. You can't bring
yeah,
everybody to the closest.
right.
That'll bring us to our next topic. But
Yeah.
yeah,
Yeah,
but
but that's something.
it makes sense.
Yeah,
It makes sense. And if you think about it, as we have spreader events or we have communities where there's a lower level of immunity or a higher level of infection, it doesn't make sense to take everybody to that one facility. And
yeah,
of course, by moving them to places where they have a lower level of infection, we bring the people who are infected to that area too. So
yeah. Yeah, I mean, I don't, a lot of the comments that I've seen on this, just to kind of wrap it up, is it's cruel to do this, that patients have a right to go where they want, that their definitive care is at the hospital of their choice. That's where the doctors are. That's where they've had past surgeries. That's where they've had, whatever the case may be. And that's the argument of, well, we should do what the patient wants. We shouldn't be dictating to them where they go. And also that element of don't bring patients to the crappy, closer hospital if they want to go to the better hospital where they are usually seen. We all know that certain hospitals have certain reputations that the care in the emergency room or even on the floors are less than optimal. And then, nobody wants to go there, right? So that's another element of a lot of the comments that I've seen with this is the people saying I wouldn't take my worst enemy to my closest hospital. So if that's what comes up, I'm not going to, and the patient wants to go someplace else, I'm going to abide by what the patient wants. That's another slippery slope, I think, too, with this is, I guess, being
well,
sort of the judge of what a hospital capabilities is in their customer service, and the bottom line on it when it comes to that.
and you can run into a little bit of a problem as a provider when you're dealing with people who want to go somewhere different during a stroke, a STEMI, or trauma, and we actually have response protocols about going to the nearest appropriate facility.
Right.
I'm not saying that you never go around it because if you're going to argue with the patient for 10 minutes and get on the phone with medical control, you could have been at the other hospital already most of the time.
Right.
I will.
I found I found that to be the better path over time was, like you said, why am I arguing? I state the case to the patient, and if they're still insistent, I get on the phone and I hand it off to the doc and let the doc make the decision.
And they're going to tell you to take them where they want to go.
Pretty much. I don't think I've ever had a doctor tell me not to do it unless the patient was like, in some sort of extremis or something like that, and I just needed to, kind of cover my ass by calling the doc to make sure that everybody was aware that I was going to not listen to the family of the patient because it was in the interest of the patient's outcome.
Yes.
Yes.
So
Yeah,
And
just some. I just thought, like you said, I'm hoping people listening, if you listen now, listening live, and you're listening to the recorded version of this, go ahead and leave us a quick comment on that in the notes if you have any recent experiences with this policy. If you're from New York, or if you're not from New York, and you another organization, another state, or whatever, let us know what you guys are doing there to alleviate similar issues with the higher call volume and people that are looking to go to the ER to get tested because they don't want to wait on some hour-long line to be tested to be told they're sick.
they're going to go to the ER and wait there with a lot of
Right.
other sick people.
Exactly.
It's,
Exactly.
and maybe
Yeah.
in emergencies, they can set it up so that you can go to non-Article 28 facilities. Maybe we can have, some test sites for people calling ambulances that are,
Yeah.
in trailers, parked by the communities to relieve that load.
Right. Yeah. I mean, I think there's other ways to handle it. I think this is sort of a blanket thing that they're trying to handle and get done to implement and maybe alleviate some of the patient load and unnecessary transports a little bit. I guess maybe they look at it, they get like 1%, change. It's better than 0%, So one thing we just mentioned before about the patient loading element, and now the computer trying to tell you what hospitals might be best, they won't be as crowded, and might be a better choice to go to, and it might not be the closest facility because of the amount of patients that have been going there by ambulance. And we talked a little bit about the MCI aspect of that, and most of the time you don't see that unless there is an MCI when they
Right.
start to tell you, okay, go to this hospital, don't go to this hospital, things like that.
You can't bring 10 people who need neurosurgery to one hospital. It's just not going to work.
I remember, listen, the one thing that sticks out of my mind is 9/11, when I had people, looking to go to the hospitals of their choice for, complaints of difficulty breathing or complaints of, whatever. And it was like the one day I could say, no, you're going to go where I tell you to go. It was very, very liberating to have that power for the day. But thinking
But
about
it's also
MCIs,
disarming to the patient. They had an event happen to them that they had no control over.
right?
They try to take a little control. They call an ambulance, and they still have no control.
Yeah, exactly. So I was thinking about a little bit about that because of the recent fire that they had in the Bronx in New York, and the high death toll there and injury, toll there. And I mean, first of all, looking at some of the images and the short video clips that are floating around social media and the news, it looks like they did a great job in managing the scene and staging and all that stuff. But I started to think of, how many people in EMS are really comfortable with managing a scene like that. You're the first person, you're the first crew on a scene like that. How many people are very comfortable with managing that? And I started thinking back on my own experiences of being the first unit on the scene for things like that. And when I was in New York, it was very, in New York City, very easy because most of the time you had a fire department was there either right before you or along with you, and you had a chief, an assistant chief, a captain, whatever.
The incident commander.
Yeah, exactly. More than willing to take over and start doing the incident command and like that. And that left me just to triage, and that was fine. Or patrol bosses, and it was pretty much right behind you on if the call came in as a potential MCI. But then when I got out of New York, was working in other states, New Jersey and upstate New York and North Carolina, stuff like that, that wasn't really the case. Most of the time when you were on a scene like that, you were in charge for quite a while.
Yeah.
You were incident command for a while. on that type of in those situations. And I felt, for myself, I felt really, even though being in New York for 15 years, in New York City for 16 years, now being in other systems and where that MCI element was a little different as far as the amount of resources that were available, right? I found I wasn't comfortable in that, you know. And I wonder how many people out there are comfortable. Let's say if tomorrow they were thrown into, an MCI and they were incident command for a good, half hour, 45 minutes or whatever it may be until other resources, showed up. For me, it took one time for me not to feel comfortable to, go home and start cracking the books and retaking classes and the FEMA class that those FEMA courses everybody takes that
100, 200, 700, 800.
Yeah, you're just taking the classes and you're just checking boxes and you're not really getting a lot out of it. And I started thinking back when in firefighter training when we did a lot of tabletop type exercises to help with scene management. The fire department's most fire departments are very big on MCIs and incident command and scene management and stuff like that. And they want pretty much everyone that's on that engine, that ladder, whatever, to be able to, be an incident commander if need be. So that was something that helped me once I did that training and was able to kind of, translate it to the EMS side and be a little more comfortable with it. But like I said, initially, I was lost, and this is after being in EMS for 16 years, and I just wonder how many people out there are comfortable with incident command, And I mean, what do you think? Do you think organizations stress enough training with that, or is that just the once every 2 years type refresher thing where they, bang out some couple of scenarios and you kind of grin and get through it?
Yeah, well, if you ask me, I'm big into training. I don't think we do enough training in that. I think the people that I see in EMS land often have a hard enough time with triage, which is the thing they would do if they were released from being the incident commander. They'd be doing triage.
Yeah.
And doing triage as opposed to being a triage sector supervisor, is I think triage is very straightforward, but I teach it all the time. But I just want to go back just a little bit on your incident command thing. I'm going to tell you, I don't get to do incident command often, and I love that. And if I am the incident commander for a while, that means that the resources that I need, because I come with my ambulance. If I'm the incident commander, it means I don't have the resources I need.
Yeah.
It's rare that we just have, people who are just sick or spontaneously hurt without an incident that's an evolving incident that needs. I mean, I welcome the fire department and the police and the special services that show up then, because if they're not there, I'm all alone. What am I going to do? If there's a fire, I'm going to throw a liter of saline at the fire. What am I going to do?
Yeah. You sit there. I remember, I forget what the call was, but I remember I was on one time and it was stuff was happening so fast. And all I'm thinking of in the back of my mind is I'm hearing more sirens coming. I'm like, okay, hurry it up. Get here because it's just me and this ambulance. And we're trying to figure out what's happening and trying to get control what's happening. And then the other end of that too is like you said, the triage stuff. Triage, like it is straightforward. My biggest difficulty with that is finding the tags that are probably buried in the ambulance somewhere. The last time somebody used them. Once I find the tags, I'm okay.
Yeah. Yeah, and there are some systems that make that really easy. You're not tying knots; you're just pulling little tabs.
Right.
Yeah, the toe tags that we used to have. I got into it a little bit before you, but I remember what we had. what we had to do in the 70s for this. It was ridiculous.
Yeah.
Yeah, but I think we've come away. I think being an incident commander, I mean, it sounds gloriful. It's horrifying. I
Oh
have
yeah.
to believe it's hard, and I know it's made some people's careers. But I remember, and without mentioning names, I remember um, in my medic class we had a person who ended up being the incident commander in a terrible collapse in Connecticut. They were There was this building that was being built, and it was like going to be 5, 6, 7 stories high, and they put these giant slabs of concrete and they pull it up by cables to rapidly create a 7, 8, 10 story structure.
Hmm.
That while the people were working there, it collapsed. It went from being a 10 story structure to a 1 story structure, and the people that were in there were between concrete that didn't stop because they were human bodies. Some
Right.
people might have been in the stairwell, they had an opportunity to survive, but the people who were the incident commanders, they were not normal after that. It was hurtful. It's a
Yeah.
hurtful thing. I was at Flight 800 way too soon as part of the critical incident um, stress team, and it was horrifying. And the incident commander, which always ends up being the fire commissioner, the fire chief, whoever is on the scene there.
Mhm.
That's not a healthy position. The decisions that they have to make, the things that
Yeah.
they have to experience, they're not healthy. And while it sounds
Yeah.
gloriful, and sometimes they get a chance to make a road show out of it, to go to a conference in Vegas to present on how they did, their thing at Flight 800, or when
Yeah.
911 collapsed, or this Oklahoma City. It may be even
Yeah.
cathartic for them to talk about it.
It's funny you say that because I know that there was a girl uh, that was on the ambulance, and her and her partner were the first on scene of a plane crash, uh, maybe 10 years ago, something like that. And like you said, it was horrifying for her, the type of thing where she never really kind of got over that, having to be in command, before the rest of the cavalry got there, you know.
You
Um,
feel powerless, even when
yeah,
everybody's there.
yeah,
It's not an easy situation.
yeah, yeah.
Ugh, ugh.
Well, I do encourage people to look for training, like you said, Dave. Look for training that can help them with incident command, with triage, with
As
handling MCIs.
as I
You know,
remember, there's a whole bunch of free training available by some of the um, national organizations, national federal organizations that will actually fly you out, train you, take you to a place where they train people on this for
mhm.
free. They put you up, you get great training, and maybe when this is over, we can list some of those
Yeah, I'll
resources.
try to I'll see if I can find some, put them in the show notes, for people. And just one final note, I will tell you that when a lot of people tend to get a little frustrated when they are assigned or they're doing the training, with the simulation type thing where they've got the make believe patients and make believe ER stuff and whatever, and it can get, if you're on the ambulance and you are doing that sort of that training, you might feel, oh my God, it's a waste of time. It's freezing out here. It's so hot out. I'd rather be doing something else. But I'm telling you, once you do it, I think you're going to find you learn a lot from it. And I know that's what happened to me in the past, where I would rather be doing chest pain calls and sitting on some make believe MCI. But as I went through the evolutions of the training, I found I was really getting a lot out of that training. So I encourage people that if you see that at your agency and you can volunteer that day to go be part of that training, even if you're not part of the ambulance and whatnot. Maybe you're part of the make believe patients. Take advantage of that stuff. Don't let that opportunity pass you by, because it could really come in handy down the road. So, and we'll just end. I guess we'll end it there, Dave. I think, like I said, encourage people to go ahead and do that, and
Okay.
do all that. And I have Ahmed's in here.
I see.
He says he has a question.
Sure.
So you can ask away, Ahmed, as long as it's nothing that I have to quickly delete. And no Josh, I guess, Dave. He didn't.
No.
He didn't pop up today.
So. Yeah. Let's see what he has to say here, or at least
give him a second before we end up. So, Ahmed, if you have a question, you'd be more than happy to.
How can you control stress during providing care to a patient?
Yeah. I guess experience is going to be. He's as a new paramedic, so I guess experience is going to be your biggest best friend to start trying to lower that. And I think knowledge is going to be your best friend too. Knowing what you're doing, understanding why you're doing it, is going to be a lot less stressful for you going into actual patient care. When you're going from the student and you've got the training officer with you, you have the clinical, rotation person that you're with, the FTOs and stuff like that. When they're not there anymore, there's just you and an EMT or you and another medic.
Jim, I need to say this because I see this in different systems, and certainly one of the systems that I know well. We often hire within the system of the county. They hire paramedics, fresh out of class. Their card is still wet. They hire them. They put them in a first responder car, and their partner is the radio. And they don't even have the opportunity to learn from a senior medic. One of the things that in the New York City system where you came from, when you were the new medic, you rode I'm thinking a couple of weeks as the third medic on the ambulance. All right, so you're the third medic, and you got good or bad. If they were good, they counseled you, they advised you, they supported you. When you went to do something, if you're going to do an intubation, your first few intubations in the back of the ambulance there or on the scene, you turned around and they had a 7.5 and an 8 ready to go for you. And you opened up the airway and you realized, oh my God, I need suction. And they were there for you. And they were there. And you were riding 3 medics. And then after your, whatever the minimum amount of time was, you became the second medic on an ambulance for you. And we can argue about how good that system is, and it comes up all the time. But when you're the second medic, if your partner didn't get out of the same class you did, if they got out 5 years earlier, maybe you got 5 years of experience or 20 years of experience, or God forbid you ride with me, 4 decades of experience, good or bad. Some people relive their first year 40 years, and some people just grow, every time. But at least you got somebody else there. The folks we're hiring now are brand new, and they're riding alone, and they don't even get to discuss the call with somebody else who was there.
Yeah.
Because they're the only medic on the call. And I see the stress when I want to provide care to a patient. It is hard. It needs to be. So Ahmed says that I feel like stress when I want to provide care to a patient, like I can't focus on examination steps. Do I have advice? Hopefully you got a lot of advice and a lot of practice in that as you went through medic school, and I presume you did. And when people say you won't rise to the occasion when things get bad, you will default to your level of training. And that's where we are. I would suggest to a person who's finding it very stressful that they seek additional training. And when I say additional training, it could be to ride on tours with other people. It could be maybe go to the ER if you're affiliated with an ER that would let you have the guidance of the doctors and nurses and PAs and NPs and respiratory therapists who
That's
are
a good
there
option, I think, for
so
some
that you
people.
can practice your skill. Listen, you're brand new. If you're brand new, I think assessment is the toughest. Intubation, that's not the toughest skill we do.
It's not the skills as much as it is the interaction and the assessment
integration
and what it is you have to do, what's the most appropriate when it comes to the treatment, the transport, and all that. And like you said, if you don't have another medic there with you that's experienced to kind of guide you or to give you feedback afterwards, it's hard to gain that confidence.
I want to hit one more spot, and it may help, Ahmed. After being a paramedic, whether or not you took any of this training during your class, it's different now that you're a paramedic. There are great courses, alphabet classes, AMLS, the Advanced Medical Life Support class. You will go through 10, 12, 15 scenarios where you will get to think diversely about your assessment and the integration of that into care. PHTLS, pre-hospital trauma life support, the difficult airway class, which is not an AEMT class, just a great class. And again, looking at PALS, find the class or ACLS for experience provider. Find the classes that aren't aimed at getting you the credential in the minimal amount of time, that expand on the scenarios, that have you go through the scenario. Oh, you did a good job on that. Okay, that's not enough. If you did a good job on it, let's talk about why you did a good job on it. Let's talk critically about what you did do, what you could have done, how that might not have been as bad or might have been better or not. It's just consider the options. Discuss your thoughts as a paramedic, which is different than as a student in the class.
Yeah,
so
I think you're 100% right. That dynamic and how you can view things is a little different. Once you're an actual paramedic, you've got your certification, you've passed all your exams, things like that. When you take these classes, you can look at it from a different lens, and I think get more out of it, get more feedback, better feedback by asking better questions as well. So I think it all kind of adds up, and a lot of it, like Ahmed, a lot of it's going to be time and experience and seeking out, people that have been doing it, and getting them to, give you a little guidance, a little feedback on what you're doing. It might be that you might be stressful, but you might be doing things just fine. And, the stress you're feeling is sort of maybe all internal. It's not really translating to the care you're giving, so have somebody look at what you're doing so you can get some feedback on what your patient care is.
So much of what we do is stressful. It's stressful to have people who are dying about you or people who are experiencing events that can leave them profoundly disabled. And it's stressful to deal with their loved ones who are watching this happen. And I can tell you, I know physicians that say to me that the stress of the job, first of all, their number one stress is the business of being a physician. That's horrifying. Going for reimbursement and coding and all of that, that's horrifying for them. But many of them tell me, listen, I'm making life and death decisions on people, and it scares the hell out of me. And number one, I'm glad it scares them. And if it's not stressful to make life and death decisions, maybe you're in the wrong business. I mean, at some point we should get good at things, really good at things, that it's easier and we're more knowledgeable. And I think that will come with a tincture of time, Ahmed. But I think our training goes a long way, and the stress of a pediatric resuscitation will never go away from me. Never.
Yeah, it's true. It's true. And like you said, Dave, I think if you're not feeling that stress for the responsibility you have with some patients, it's the job. It's what the job is, and you should be feeling that stress when you encounter some of these patients.
It's normal to feel stress in stressful situations.
Exactly. And it doesn't have to be an MCI. It could just be that one patient that, is got 10,000 different things going on at once, and you're trying to figure out which one to, manage first. But don't forget the ABCs, BCA, BAB.
Yeah. And managing stress is something that we can learn. There are procedures. I don't mean just sitting there contemplating, not.
Yeah.
I'm not talking about transcendental meditation, which is not a bad thing either. But there are ways to manage stress. A lot of them involve colleagues. A lot of them may involve strategies, behaviors that you have.
Yeah.
It needs to be explored, and there are courses in it. There is advice for it. I'll just a real quick one is the PTEP class, Psychological Trauma in EMS Patients, which has a component dedicated to the stress of EMS providers. And if you didn't know this, Ahmed, the number of EMS providers who are depressed or contemplating suicide or succeeding at suicide is 10 times higher than the regular population. So you're not alone. If you're feeling stressed, there is a ton of stress. And if you need help, there are resources for that too. And hopefully your employer can help. And if you really need help, shoot us a note. If you urgently need help, we're not going to walk away. You just shoot us a note. You got us.
Exactly.
History taking. AMLS.
Yeah, exactly. Yeah. All right, Dave, let's end it there because my battery's almost dead.
Okay.
And I don't want to just zone out here. So, all right. Everyone, thanks for joining. Ahmed, thanks for your questions. People, thanks for liking. Be sure to go ahead and like the show. I really appreciate it. And we'll just end it there. All right. So, as always, I am Jim Hoffman.
And I'm Dave Brenner.
Stay safe.